Thank you very much. There is a question that came up on this little box from someone in the website, and I feel like I should at least read the question, and anybody wants to respond to it. And before we get going, I think we owe it to them to do that. And I managed to goof this up, and I don't have anything on my screen right now, so if you can reset it, would be great. But the question was, there's been suggestion, is from someone from Rob Bohr from the BMJ, and the question was, we've been advocating that patients be more of active participants, and we've already talked about the need to train investigators about the issues in clinical trials. So now, how are we going to train and teach patients about the clinical trial process, and so who's going to do it and who's going to pay for it? So I don't know if anybody on the panel or anybody in previous panels wants to respond to that, but that's was the question that came in from the website.
Hi, Gail Pearson, NIH. At least for children, there's a Children in Clinical Studies website that NHLBI hosts and was also contributed to by the former National Center for Research Resources as well as NICHD and some foundations that provides at the 7th grade level an overview of what it means to have your child be in a research project. It contains both didactic information and video material that includes scripted child actors as well as patients and their families both who participated and didn't participate in clinical research. So if a family is approached about having their child participate in clinical research, they can go to this site and go home and talk with Aunt Mabel and Uncle Fred about clinical research and learn some of the terminology. So that's one solution.
Nancy, I think you may have helped to raise this question. Do you have any quick response to that?
There's multiple resources online that teach advocates, lay people about science. The challenge is being one of me in a room with all of you, and there's usually 1 or 2 or 3 of us in a room, and we're vastly outnumbered by all of you. And so it's hard to feel comfortable talking about science if you're in that situation. And that's, I think, the biggest challenge. We have a research training program through Fight Colorectal Cancer. We call it the RATS. And just getting them to open their mouths because they're so afraid of being stupid, looking stupid. It's really hard. So that's the challenge to me. It's not training, it's providing forums where people can learn how to do what they do.
Can I respond to that? I just want to say, we're all patients at some point in our lives, and when we all get naked, as you pointed out yesterday, we get a lot dumber too. I don't think, and we don't know what questions to ask about our own health care. I don't think you should ever hesitate to speak up.
Well, clearly that's an important question, especially as we try to engage more of the stakeholders. But anyway, let's move on to this session, which is strategies going forward. We have a panel discussion format, and let me just quickly introduce my colleagues. And there's a set of questions that were prepared. They can each speak in turn to any one or more of the questions they choose to before we open it up for general discussion. But representing the federal funders is Mike Lauer. Non-governmental funders, i.e. the American Diabetes Association in this case, is Rob Ratner. From the FDA, you've already met Bram Zuckerman earlier. For private payers, William Crown. Sure, there you are. And from industry, Peter Held. From patients, Kate Ryan. And from clinical researchers, Elizabeth Christilius from the University of Iowa. So, I don't know whether I should flip. I missed one? Ah, yes. Introduce Rosemarie, yes. How did I do that? Anyway, Rosemarie Hecken from the Center for Medicare and Medicaid Services. My apologies. So, I don't know if I should flip a coin as to which end we start on, but at any rate, I will, since I was so remiss in not introducing Rosemarie, I'll start at the other end and give you some time to think. So, Elizabeth, why don't you start in with just a few thoughts about any of the questions that were listed or anything else that comes to your mind based on what you've heard over the last day and a half. And what we want to do is try to get ourselves focused on where do we go from here, because we've had a fantastic day and a half discussion. We've all been to lots of fantastic days and has discussions, but if that's all we get, it'll be a fun day and a half, but we need to figure out where do we go from here. So any thoughts you have on that based on what you've heard?
Well, thank you. My name is Betsy. Chrysillus is just a tough name to say, so I'm happy to go by Betsy for those of you who don't know me already. And I want to congratulate you all for staying here and staying so wide awake at this late hour in the afternoon. I wanted to, in thinking about the different things I could say, I thought I would try to not repeat what I've heard, because I think so many of the challenges and opportunities were vocalized so eloquently today and in so many different ways. And so what I thought I would comment about today is just about how we might be able to do what Nancy asked us to do yesterday, and that is to cook rice, right? Talk doesn't cook rice. So in thinking about what I would do at my home institution to try to seize the opportunities or challenge opportunities that we vocalized today, I thought about some of the initiatives that were going on. And first, I should just say what my home institution is like. I'm at the University of Iowa. It's an academic health center with a tertiary care hospital and a sort of rapidly growing set of small hospitals and clinics that are sort of networking up and collaborating under some of the new types of care organizations that we're seeing in our state as well as around the country. Along with that networking that's happening locally would be the networking of electronic infrastructure and opportunities to collaborate within the CTSA organizations and multi-center studies. And so it's my hope that some of the lessons from today we can really internalize locally to make ourselves really good collaborators for multi-institution studies. And so I just thought I might say a couple words about what I think we're doing in Iowa that should put us in that position, with a goal toward creating an accessible, reusable infrastructure for clinical researchers at our institution so that they can be these good collaborators in multi-center studies, as well as smaller scale studies in our home environment. So we've been able to take advantage of the CTSA award, our participation in the NIH Health System Collaboratory, a growth of our research data warehouse, and some investments in some innovative web-delivered patient consent and patient-reported outcome data collection tools so that we can pull together some of the pieces of that infrastructure. And we have a few ingredients to our approach. One is that we have a core team. This is true team science, and I think our team has expanded dramatically to include not just those with expertise in conventional clinical trials and biostatistics and epidemiology, but also health services researchers, computer scientists, ethicists, education and instructional design experts, study coordinators and program managers. And so that core team is meeting actively with the IRB, for example, to try to formalize some guidance about some of the key issues that we've talked about here today, including what we can do about when and under what circumstances we can have electronic documentation of consent. A number of other aspects related to whether we need honest brokers for recruitment, whether we can have HIPAA waivers. You imagine of the variety of the types of issues that we're discussing with our IRB. And it helps to have a concrete example to do that around. So our demonstration project within the Health System Collaboratory is allowing us to do that. Another way we're leveraging leveraging our CTSA award is by dedicating key resources to embed a research data developer in our hospital information system team so that we can be developing research tools for the EPIC system within the team of the healthcare information system with dedicated resources to those research tools. We continue to support some innovative methods that are running outside of the EHR, and those tend to emphasize patient-centered techniques for web-delivered interactive informed consent, as well as opportunities for online participation of patients in our research projects to provide them with something beyond being a subject and more useful information that might make them more engaged and as active participants in the research. We provide protocol development support for clinical researchers, particularly about the EHR-derived variables and protocols, including providing access to validated EHR algorithms. And we are moving as quickly as possible to try to move away from the concierge model that really focuses on everybody having access to a human, to try to get some of the knowledge out and more available to the clinical investigators themselves. So there's some tools that are being developed that would help clinical investigators directly query the EHR to identify numbers of subjects who might be potentially eligible for their studies. As I mentioned, we're engaging patients as partners. We routinely do usability testing and participatory design for new user interfaces. And we are developing new online platforms for participation of patients. We have conventional access to methodologists, as all CTSAs provide. We include in our team people with econometrics expertise in adaptive designs, and statistical genomics, which I think are key methodologies that are important for today's work. And lastly, we do provide support for methods development, for example, for the simulations that are needed to do good adaptive trial designs. So those are just a few of the kinds of things that I think we're doing in our institution that should help us to be more efficient and be good partners in collaborative, large, simple trials. Thanks.
Thank you. Rosemary, would you like to offer your comments? What you've heard or any thoughts you have on what you've heard today?
Hi, I'm from the Centers for Medicare and Medicaid Services. Well, maybe we're the elephant in the room because we pay for the insurance of more than 80 million people in this country. The elderly, children, women, and disabled. So we are major consumers of research, even though about more than 90% of what Medicare currently covers has no real science behind it, but we're trying. I was really glad to hear that a lot of the use of LSTs is going to be for, or is for in-use technology, in-use drugs, in-use therapies. We rely on that kind of information to inform clinicians, but we also have, in the recent past, pulled back coverage based on outside research. So we can stop covering something if we decide that the research is inadequate or new information comes out that shows there's a harm, and we have done that. But I want to caution everybody that we don't like it if you don't include Medicare beneficiaries. And we have several ways to support research to include our beneficiaries. We pay for patient care and ID trials. We pay for, we have our clinical trial policy in which we pay for patient care in any kind of government funded or sponsored study. And the last thing we have is our coverage with evidence development policy, where we can, this is generally for new technologies, although we have used it for old technologies, where we've allowed coverage of something only in a trial. So only patients who are participating in that trial will get covered for that item or service. So hopefully we can be of some help there. Anything else? One thing I'd like to caution, in large trials with very small, statistically significant but minor results, is to do subgroup analyses to kind of determine who in that large population is really benefiting from whatever it is you're doing. We don't really, I can't see, well, I think we need a lot of training to be able to digest information that comes from EMR type trials. And maybe you can educate CMS, because mostly what we use when we review our evidence is randomized clinical trials in the strictest sense. So I think we need a lot of education there. I think that's all I have to say.
Okay, thank you. So to go back to the other end, Kay, do you have any thoughts?
Hi. So I'm going to say just a little bit at first, and I put some context to my comments. So I'm here as the patient representative, I guess. So Nancy's second in the room, I suppose. So I'm at the National Women's Health Network, and part of what we do, and the reason we're interested in this, is sort of it's health access and health safety. And health safety can mean a lot of different things. In our case, it's mostly wanting to know how particular things impact women. So women in clinical trials in general, particularly for trials that aren't looking at women's specific diseases. But I think with large sample trials, what I want to touch on, and part of the other things that we do, we consider ourselves an evidence-based healthcare organization. We're membership-based, and we have a clearinghouse. So women since the 70s have called in. They now email, but it used to be like a big library where you would phone in your questions. You got a diagnosis, and your doctor told you this was the only, fibroids, and you were told hysterectomy is what you have to do, and you're 32. And so we provide what evidence there exists. So in terms of, I keep thinking of this as we kept talking about physician friend and physician scientist, and patients, get evidence and say to their doctor, what do you want? What do you think I should do? A lot of patients want to know the options, and they understand that the doctor doesn't have every answer if it's presented in a particular way. So we tend to give those women that call us, here are your different options, here are the different risks, benefits that go with that. Take this back to your doctor and talk this through with them. And so in the context of getting answers for women, this is where we see LSTs being useful and beneficial, and where we're supportive of this, is getting answers on the evidence, where there are evidence gaps, and as Rosemary just said, in use treatments. We're talking about comparative effectiveness research or duration of use of particular drugs, whether it's bisphosphonates, which was an up in the air question. How long are we actually supposed to have women on these? Tamoxifen, I believe, was an LST that was looking at 5 or 10-year use. So what we see is kind of trying to get answers that will actually give women information they want to make an informed medical decision, where they feel comfortable with the decision that they're making. And as well as the access piece. When we're talking about LSTs, the thing that pops to me that hasn't really been talked about a lot, though Rosemary also just sort of hit on this as well, is with broad inclusion criteria, we're getting people who are often excluded from clinical trials, especially RCTs, whether specifically excluded outright because they don't meet they meet all your typical exclusion criteria, age being a big one, and weight. We exclude people who have very high BMIs, even though most people in this country have very high BMIs. Pre-existing conditions, so we're not looking at concomitant medications. And then the indirect people that we're leaving out of most research, your low-income people, communities of color, people in rural areas. So hearing the kind of mail packet the mail order packet medications, that was something that is not disproportionately leaving out people in rural areas. So these are the populations that we see benefiting from LSTs, that are answering simple questions and getting these people who would otherwise never be included in research, and who might have, whether it's the age pieces or race ethnicity pieces, there might be different answers for those people. What we often hear, especially from older women of color, who call, typically not email, is this is what we know if they have a doctor who's really talking through the evidence, and then they always have the caveat of, but there weren't very many older women of color in the trial, so this is what we think we know. We really don't. We can't tell you what this means for you. We don't know what this means for you. And these are the people we'd like to start getting answers from LSTs. Obviously, there are all of the barriers we all talked about, one of the big ones being informed consent. So these same populations are populations that can't read an 8-page legalese informed consent document. It's not, they can read it, they're not going to know what it means. And the truth is, if you're not a health professional or a lawyer reading through, you can be an engineer and you still aren't necessarily going to be able to figure out what your 8-page, 9-font print informed consent document is telling you. And so we would love to see going forward some reforms to targeting which populations are being included in research and trying to decrease those barriers, like very complicated informed consent documents, which is something we think LSTs with simple questions and broad inclusion criteria could really move things forward on. So we've also had this sort of combination in-use treatments, sort of looking at comparative effectiveness research questions, and then these questions around NDAs or PMAs if we're talking about devices. So we do a lot of work with the FDA as well, mostly trying to make sure women are included in trials and data is broken down according to sex. But in moving forward, everything doesn't need to be done all at once, and we think there are probably steps that could be taken sooner, looking at in-use treatments rather than the amount of safety data or fields. Whether they're unnecessary fields in NDAs, there probably are, and Rachel Sherman just said there are, so I'll trust her on that. But there probably are more things we need to know in an FDA application for an NME, and that's fine. But maybe that's where we shouldn't be starting with LSTs. And this, every once in a while, the chairs have said we don't need. We're not talking about every intervention can't be done using with an LST. So we should probably stop talking as if this is going to apply equally to everything. It isn't. And so I think just the one last thing I think I'll say and stop is one thing Nancy kept bringing up. And Nancy, you should correct me if I'm interpreting this wrong, but just in the last question about being the patient in the room and not feeling like you want to ask a dumb question. I think it's true that everybody feels like a patient at some point, and when you're sitting on the table, you don't want to ask a question, but I think it's different in this context of being in this room, I think is what you were getting at, yeah. Without having a PhD or an MD and sitting in this room and trying to bring patients' concerns to the table. That's where we, the patient, or consumer advocates, because consumers are, patients are consumers of healthcare, and however you want to talk about it, how we can bring things. So looking at NIH, or I sit as a consumer rep or a patient rep on a data safety monitoring board for an NIH trial, and being able to, and I'm trained to do this, but making sure the questions answer, the research questions answer things real people want to know. These people need to be included in the research question development process, not just bring in a patient rep towards the end of it and say, look, we worked with patient reps. You guys think this is a great idea, right? Great, off you go. But patients don't want to know their, the hemoglobin levels. They want an answer that makes sense to them. So maybe that does make sense to them, but we need to talk about it in a way that makes sense to patients. So having a patient rep involved in your trial, whatever type of trial that is, isn't usually going to cut it. There should probably be more than one, so they feel like they have some support in the room. Not that they think people are going to treat them badly, but they sit there quietly the whole time. You see this on FDA advisory committees all the time. They just sit there really quietly because they don't want to sound stupid in a room full of doctors. So I think that's something to keep in mind. Moving forward, incorporating patients means making sure their voices, you're empowering them to speak. So thank you.
Thank you. Graham, do you want to go next?
Okay, I'll go. First of all, I think that a lot resonated with me today. It's clearly a situation where we're in the 21st century and we need to consider how many standard paradigms should be altered. Not that certain clinical trial paradigms need always to be changed, but certainly I heard good arguments for one size doesn't fit all, and the LST paradigm can be extremely helpful. That's the good news. The bad news is that my brain seems oversaturated because I've heard so many good ideas, and I think we need to figure out how to start to approach the problem and what are the key questions from a hierarchical perspective. And what I would suggest, Dave, is that perhaps it might be useful to, since you and Rick were taking good notes, to break up the ideas into the low-hanging fruit bucket, the middle-hanging fruit bucket, and the high-hanging fruit bucket, and then to prioritize within those buckets. To give you an idea, for example, the discussion that Rick just had regarding training of project managers and streamlined case report forms, I think that can be in the low-hanging bucket. On the other hand, Devin and Ruth had a marvelous discussion with Rob Califf on the informed consent issue. As someone who has dealt with that over a decade, I would underline the complexity of that issue, but as Devin pointed out, perhaps now there is a rare, perfect moment where under her leadership and others, this can really be approached in a responsible fashion. But that's 180 degrees apart from the low-hanging bucket. Then, in addition to doing that, I think there's a situation, again, where clinical trials methodology has improved, but there's a need to make sure that it's disseminated to all who are interested. And here I think a demonstration project where HHS would be a key component with other stakeholders might be quite helpful. And that's where I see Dr. Lauer on my left and Rosemary on my right. And Mike, I know, has been thinking very thoughtfully about this whole field, and I would be very interested in hearing his comments as to what sort of demonstration projects could involve an HHS collaborative with other stakeholders to really help keep the ball moving. Thank you.
Thank you. Actually, I'm glad you suggested that, because as I was struggling for what to do with the last session, that was what was crossing my mind. That there's been so much here that to sit down, some of us, some group of us, sit down and look through the transcript and/or presentations and sort of categorize what we can, I said, pick off the low-hanging fruit, because we've had an incredibly rich and diverse discussion. But to try and summarize it in the last half hour will be a challenge. But there are some thoughts which I'll share later that I have already come to. But anyway, thank you, Ram, for your comments.
Sure. I cannot give you an industry view, but I'll give you some personal reflections based on actually more than 30 years of large clinical trials, which is sort of almost scary when you look back. So I've seen NIH trials, I've seen academia initiated trials, and now for many years also industry trials, mainly large ones. But I also feel that, I mean, much of the discussion today has been focused on simplicity. And I think, why do a complex trial if you can do a simple one, regardless of whether it's big or small? So I'm sort of biased. I'm always simple if you can avoid doing it complicated, of course. And my sort of personal background with I mean, experience the power of simple trials was actually in the early 1980s when we did, and I was on the academic side at the time, the Miami study with IV beta blockade to acute myocardial infarction. Huge study at the time, 5,500 patients, very complicated, lots of data collected, although not like today, of course, but still. And that study came out with a relative risk reduction of, if I recall correctly, 14%, which was just not significant. Only months later, the ISIS study came out, 3 to 4 times as big, almost identical protocol, but with a one-page CRF. And of course, with about the same relative risk reduction, but highly statistically significant. And that sort of made me aware of, well, numbers matters, of course, and you can also do it in a very simple way. It was criticized at the time heavily for the way it was done, and maybe it wouldn't hold today's standard, but it was an interesting experience. And of course, some of you maybe all of you know about the vaccine trials in the 1950s. In a small country like Sweden, where I come from, we randomized 700,000 kids out of a population of 7 million into a study which very clearly showed the benefit of polio vaccination. And I know there was an even bigger effort in the US. Some reflections from today. I mean, there are many. It's been good discussions, I think. We, from the industry side, always, of course, need to satisfy our customers. And that's, of course, patients, it's physicians, it's regulators, but also payers, of course. And payers are sort of the new kid on the block since 10 years ago. And a complicated group of individuals, actually.
Yeah, we are.
Because when you talk to payers in the US, you get one answer in one place, a different answer in another place. And if you go to China or Japan, you will get very different answers. And I think that's one of the forces that is driving us sort of still having to be a bit complex in doing trials, because when we do clinical programs, they have to be global and they have to fit sort of everywhere. And that means that you need sometimes to collect more data than you would feel you would have to satisfy those specific needs. So it's a complicating and a bit unpredictable factor, because it's so difficult to get a clear response what's really needed and what's interesting in the end. Let's see now. I had a few more things. I mean, we've talked much about infrastructure, and of course, it would be great if we could get closer to the ideal picture we've seen today, and has been possible even to implement in certain areas. But again, in global development programs, it's a tough challenge, of course. You need all these systems to collaborate, and maybe in the future, and I hope in the future, that will be possible, but it's still quite a challenge, of course. I also want to actually compliment the FDA. Not sure if anybody's still here from the FDA, but because, I mean, small things matter, and I think that the guidance that came out last year about sort of monitoring, focus on the important stuff. I mean, we've been discussing this at clinical trials meetings for decades, but nothing has really happened. But suddenly when the FDA came out with some guidance telling us the obvious, at least in my close area, people react and say, maybe we should do something different. So I think it has an impact. I know it's been slow, and I think it will have an impact when time goes by. And the same is true for the adverse events reporting and the new guidance on that came out. So I think things are moving in the right direction, but of course there is a long way to go. But I belong to those who think there is a big potential, and I think much of what we've heard today about the possibility to simplify, the possibility to decrease cost and the resource requirements are big without sacrificing in any way safety or anything else. And we just need to be smarter in the way we do these things.
Peter? Rob, you want to go next?
Well, thank you. I come to this meeting after 30 years of doing clinical research in large, simple trials, large, complicated trials, efficacy trials, and effectiveness trials. And 6 months ago, I changed jobs. And now I'm responsible for guidelines and how to use those data and what it means and how we actually begin to apply it. So one of the first questions that was posed is, what are the barriers? The first barrier that I see is frank denial in public policy. We've got Peter Orszag, who at an IOM annual meeting 2 years ago said, sticking with practice guidelines should be de facto defense against malpractice. From a physician standpoint, that sounds pretty good. Then you read Rob Califf's papers and you find that most of the practice guidelines are based on expert opinion and aren't based on evidence basis. That becomes a problem. What we heard yesterday was very interesting, that most patients don't want to hear their doctor say, I don't know. Most doctors don't want to say, I don't know. because we've come from a history where the only thing we could do was reassure our patients because we didn't have therapies. Now we've got lots of therapies, and we do what we're taught to do, not necessarily what's the best thing to do. So we're beginning to shift in terms of how we utilize data, information, and what we should be doing. So the first barrier that I see is this public denial that we really don't know as much as we think we do. And there's this incredible need to improve the evidence base upon which practice guidelines are founded. The next barrier that I see is participation. And over the last couple of years, I've been able to temper my innate cynicism with lots of data that has come out on behavioral economics. And it's really pretty simple. People do what they're incentivized to do. And so if, in fact, we are able to design systems that incentivize patients, subjects to participate in clinical research, to incentivize clinicians to enter their patients into clinical research and to participate, to incentivize payers to support clinical research, to come up with the right answers, because the right answers ultimately are better for everybody, we win. I don't have all of those incentives. I think that's one of the steps, is to identify what we can do to bring those people into the discussion. And bringing clinicians, payers, and people with disease into the discussion is absolutely critical in asking the right question and in developing the appropriate primary outcome. So here I need to speak for my constituency of the 26 million people with diabetes and to say mortality is important, but if I have to live with type 1 diabetes for 65 years, I want to know what's going to make my life better before I die in 65 years. And even with type 2 diabetes now, we're talking 25 to 30 years. Mortality is important, but it's not the only outcome. And we really need to be talking to our subjects about what's important to them in terms of the day-to-day existence with disease. In doing these studies, we need to be looking at methodologies that are adaptable. So I've been involved in an NIH trial trying to answer the question, what's the best way of treating type 2 diabetes? The study hasn't started yet, and the treatment algorithms are already outdated. We have situations where the studies take so long that once they report out, they are no longer meaningful. We have to be much more flexible. We need to be much more adaptable. And we need to use analytical techniques that actually provide us with useful information. So not just a p-value of less than 0.05. This didn't occur by chance, and the mean did better in group A than the mean did in group B, but rather to begin using more innovative approaches, whether that's Bayesian analysis, recursive partitioning, identifying the probability of response or failure, and looking at the predictors of response or failure so that we can decide what it is we're ultimately going to do in terms of developing guidelines that are meaningful, that healthcare providers can actually utilize, that medical decision-making actually begins to make sense, not just, this is what I was taught to do.
Thank you. I don't want to get into a long discussion of methodology, but my only comment was that methodology or analysis will never rescue a bad design. So, anyway.
Well, I've been asked to put on the hat of the private payer, and as I think back over the last couple of days, several themes jump out at me that we heard from a payer perspective. And probably the biggest one was asking the right question. And so we got this asking the right question from several different perspectives, and depending upon who you were, the question was different. From a payer perspective, the range of questions is mind-bogglingly large. You know, they, on the one hand, they need information around real-world effectiveness and safety at the point when they're making coverage decisions. And I think this was behind Penny Moore's question earlier when she was asking about kind of non-core data points in phase 3 trials where pharma companies are often, you know, they're powering their trials for efficacy and safety for regulatory approval, for marketing, but then they want to be able to have some information on healthcare utilization so that they can present that to the payers, so the payers can model out, you know, what they expect in terms of value if they cover a new treatment versus an existing treatment. So Lou Sandy was saying, yes, narrow, but not too narrow yesterday, and I think that's what he was getting at. There was also a focus on a speed to answer, because in a healthcare system, really don't have a lot of time to sit around waiting to conduct trials. So the whole sort of process associated with any trial in terms of developing the protocol and IRB approval and then the collection of the data, it takes time. And given the number of questions that there are, that's an issue. So how do we sort of speed that process up? And simple trials help. They move us in the direction of speeding things up. But I think there's a kind of an optimal mix in there somewhere between what questions do we need randomization for and large simple trials for versus what ones could we answer with observational data. Another theme was the question of fitting into clinical practice. So anything that sort of interferes with provision of care in the doctor's office, and this is particularly true for primary care docs that typically don't have the infrastructure for conducting clinical trials, just as a real deterrent. You know, most in the studies that we've done, we find typically that only about when we approach primary care docs for studies, it's around a 5% or so acceptance rate. So if you're going to recruit patients through a primary care doc and you're only getting 5% of the doctors up front, and then say there's a 50% acceptance on the part of patients, you're shut off from 97.5% of the patient population right from the start. So the theme that we heard about, you know, are there ways where we can go directly to patients if we don't need the doctor for clinical judgment and so forth, is another way to address that problem. And we find that when we go directly to patients, we get about the same acceptance rates as when the doctors approach the patients. So you get about a 40–50% recruitment rate going directly to patients versus, and you get about the same when doctors recruit them. The final sort of theme was this translation of research that we heard. So it's great to do research, but from a payer perspective, they want to actually translate it into clinical practice, and then actually measure what happens. So interestingly, there's this large simple trial aspect on the front end in terms of generating evidence that kind of informs decision making around coverage and treatment and so forth. But there's also, once you sort of have your strategy for what it is you're going to do, actually implementing it in the healthcare system, and then maybe that's another trial where you actually measure whether, what the effect of it is in actual practice. So from an opportunity standpoint, I think we heard a lot about data and data infrastructure, and particularly around electronic medical records. And Rich Platt mentioned the issue around the administrative data on the claims side and the value that that has, and particularly when you can put those two things together. Because the administrative claims data typically, from a payer perspective, has very good information on healthcare encounters across treatment settings. So it's pretty complete in terms of healthcare utilization. all kinds of questions around data quality and so forth. But then if you can link it with the clinical information from the EMR, then you can begin to control for disease severity and some of the things that are typically challenges with working with claims data alone. And the EMR, that deals with some of the EMR issues around being very site-specific as well. And that offers opportunities around being able to look at heterogeneity treatment effects, because when you have those big populations, the heterogeneity, you can capture a lot of that on the claims side, and then you can focus your primary data collection on the specific endpoints that your study is designed to go after. So we have lots of examples of great data systems that are in place already, like the HMO Research Network and the VA and Kaiser itself and CPRD and so forth. But still in the US, what's the number now? About 80% of medical records are still paper. So in terms of being able to do clinical trials and do that electronic medical linkage on a broad-based basis, we have a long way to go. So I would sort of, if I had a wish list, my focus would be on creating the data infrastructure for creating those data linkages on the front end. You know, the HMO research networks, the VAs, and so forth, but on a broad-based basis. And then using that as the platform, basically the sampling frame for being able to do large, simple trials for the questions that matter. And that would give us the opportunity to be able to get at this thing I was hinting at yesterday where, you know, where do we see differences in outcomes? Because if we've got observational data on patients with diabetes, and when we also are randomizing those same types of patients, we can begin to look at, you know, estimates of treatment effect in a randomized context and in an observational context. And we may find that there's this set of questions over here where we don't need to do randomization. We get pretty good answers. But there's these over here where we really need to focus on large, simple trials. And then finally, the challenge around that is changing, getting the kind of the cultural acceptance of the need for the infrastructure to put in place and then the funding to have that infrastructure.
Thank you. You know, we have lots of examples which would be fun to get into, but not at this hour, about where observational studies have led us to different answers. But I think that for me the question is, what's the stake? What's the risk of being wrong? If the risk is high, then I want the best evidence I can get. If it's a matter of subtle differences that may not be life or death or quality of life changes, maybe I can live with the observational studies. But at any rate, that's
and I think that's a valid point. I don't think there's any doubt at all that randomized design is the strongest design. But the issue is that depending on how the trial's designed, it may be answering the wrong question.
Right.
So there's also, I think, a multitude of evidence that clinical trials have led us astray as well, where we've had evidence from clinical trials that certain treatments are better in some way, more efficacious. They may be more efficacious, but they were, you know, mortality endpoints that weren't captured and so forth. And those were picked up in observational studies. And then when trials were done to look specific at mortality endpoints, then we pulled products from the market.
The problem, just to comment, the problem, of course, with observational studies is that you need really fairly big differences of treatment effect. I mean, 2 or 3 times, I would say, which is unusual.
Yeah.
A further footnote, I think we live under the illusion that from even the best large randomized trials, we have a precise estimate of treatment effect. We have a precise estimate of treatment effect of patients who happen to volunteer.
Yeah.
And so, and there's nothing wrong with that, but just keep that in mind when we start quoting numbers. It's different. Anyway.
Thank you. I think we can say that we are in a Kodak moment. And the question is whether or not it's a beautiful picture or whether it's yet another example of a colossal failure on the part of the establishment. And hopefully this meeting will lead to it being the former. You know, yesterday when we started this meeting, I showed you, I brought as a prop an Instamatic camera. And thinking about it, that camera was hardly Instamatic. I remember both my parents had those, and I got one also. And you had to go to the store, and you had to buy the film, and then you had to put the film in, and then between every picture, you had to advance the film, and then you had to take it out and put it into an envelope. And I remember it was a ritual in the family where I would take a walk with my father and the dog, and we would go to the mailbox, which was 2 blocks away, and we would drop the film in, and then magically 2 weeks later, the pictures would come back, and I couldn't remember what they were pictures of anyway. And it was hardly Instamatic. And yet, we now know, of course, what happened. We know that Kodak itself invented the digital camera, and yet they went under. Now, they weren't stupid. They were listening to their clients, to their customers. They were doing their own research and development. They were doing their own analyses. But the problem was that their fundamental assumption was wrong. Their fundamental assumption was that the future was always going to be based on film, and that business model was wrong. And as a result, everything that derived from it failed. The incentives were wrong, and along came the disruptive technologies, which essentially everyone in this room has, because we all have one of these. They then completely passed them by. Now, if we think what happened in the world of digital photography, the goal was actually reasonably clear. People wanted to develop a way of taking pictures that did not require film, that did not require the ritual of buying the film and sending it off for development. They wanted a technology that would be very simple and easy to use, that would yield good quality pictures, and that would give us pictures at a very low marginal cost. And so if we think about what we're doing here, the goal is also reasonably clear. We want answers to important questions, and we want answers that are defensible and unconfounded. We want answers that apply to patients that are seen in the real world or people that are seen in the real world. We want answers that are robust and statistically believable, and we want to be able to get those answers at very low marginal costs. And one of the ways in which we do this, not the only way, but one of the critical ways in which we accomplish this is by engaging and conducting large, simple trials. And we've seen some very nice examples of how this can be done. Just as the digital camera came out in 1976, it wasn't a pipe dream. We have seen some very nice examples of that. A very nice non-NIH, non-American example that we saw a few hours ago is a taste trial that Chris Granger showed us. Half of all patients in that particular universe who are undergoing treatment for acute heart attacks are enrolled in that trial. And it's being done at a cost of $50 per patient. So this is a trial which is going to yield a robust and believable answer, and which we know is going to apply to the real world because half of the real world participated in that particular trial. And that could be a model for us. So where do we go from here? Well, what's interesting is that today JAMA published an online article, and by the way, you know, the old technology of reading articles in journals would be that you would have the paper journal, but I use my telephone to read articles. And so this is what it says. This is an editorial that's written by 2 people who are well known for their research on the scientific enterprise, Hamilton Moses and Ray Dorsey. And they write, individuals affected by serious medical conditions are impatient with the pace of discovery. Recent examples of approaches aimed at increasing speed and lowering cost include patient-initiated clinical trials, social media as an aid to trial recruitment, tablet computer monitoring technology, and novel ways to validate self-reported outcomes. Although the long-term success of such approaches remains to be determined, these changes will surely alter government's role, destabilize universities and teaching hospitals, and disrupt the technology cycle of the past 60 years. So what do we need to do? First is self-diagnosis, and hopefully that's a big part of what we've accomplished over the past couple of days. Are we going to go down the route of Kodak, or are we going to go down the route of IBM and Apple, 2 companies that successfully reinvented themselves instead of allowing disruptive technologies to pass them by, actually participated in it and led it? A willingness to listen, a a willingness to test alternate models and technologies, a willingness to do lots of experiments, and particularly experiments that are going to fail. Bram, I think you're right, and Mike, I think you're right. We need to change our investment model. We need to engage in a number of demonstration projects. I'm very happy to say that to some extent that's already happening. The healthcare systems collaboratory is a great example of that, where we have 7 demonstration projects going, plus an outstanding coordinating group that's going to be investigating this in more detail. But the hope is that as a consequence of this meeting and similar meetings like this, we're going to have lots of these projects going, lots of projects, lots of large simple trials, and eventually we'll figure out which business models will be the ones that will eventually take over for the Instamatic camera.
A very timely editorial. Thank you. Well, I may just add a few comments myself now rather than a little bit. I was looking at my hotel room this morning and staring out in the direction of the Capitol and realized that there's a lot of discussion about the fiscal cliff. And it struck me that we are approaching a research cliff that we just can't sustain, and it's going to happen sooner or later, for sure. So we need to find ways to make some changes, and hopefully there's room for compromise. I, along with Peter Held and others around me, really strongly believe that we should keep it simple if at all possible. And actually, I worry as we talk about the LST and the EHR environment, because we're like sending me to the grocery store when I'm hungry. I can load up the cart because it's just there. And so are we going to be able to discipline ourselves enough to not load up everything that's available to us because it's endless? We already have many, many examples of data that's rotting in storage bins, never been used, never been seen the sight of day. And I'm also impressed that whether it's industry or even academic sites, all that data that we did collect that was so useful, that the investigators who demanded it rarely come back and say, can we write that N plus first paper. It just doesn't happen. So we can do some low-hanging fruit, Brown, by just taking a serious look at what we're collecting that we just never use. One of my stalking horses these days is the issue of adverse event reporting. I think we have the most ridiculous system in the world right now because it's a passive system. At least the environment that I see, it's a passive system. There's a problem with that. And it's usually free text that we code in some way. And I sit on endless monitoring committees where I see pages and pages of tables that's got zeros and ones in columns that no one can figure out what it means. It's so granular. And if you lump it to a higher order body system, you now add noise to a signal. And so it's the perfect way to bury a signal. Either you make it so granular you can't see anything, or it's so coarse it's drowned out by noise. That's what we do, and we call that safety. So it's even more serious than just collecting the data on the first 2,000 patients. We are doing, I think, a very inadequate job. So we can do a lot of improvement, and it would save a lot of data collection and a lot of cost. Many of you, and certainly Betsy, alluded to the CTSA network. It's not the answer to everything, but it's a network that I think we should take advantage of. It's 60 medical centers who have been mandated, if you will, to build data warehouses from their EHRs for the purposes of research, and at least in the current days, a lot of pressure to network those data warehouses to do potentially large epidemiological studies or large and simple clinical trials. We're not there yet, I think, but we're moving. There's examples of attempts already. But I think we can take advantage of that, and clearly, it's not just CTSA sites. There's many other examples, but we can take advantage of these and many other examples. I believe that it's the IT problems will be solved in the near future, and it's more as Rob Califf said some time ago. It's do we have the will to do it? There are some, I said, some low-hanging fruit. There's some others which I didn't call high-hanging, but I call them evolutionary changes in the issue of policy. Obviously, the legal and ethical interpretations of the current regulations may need to be done. They probably were interpreted in a different time for different challenges and need to be re-examined in today's world. but that's, as you implied, it's going to take time. Was impressed with the discussion yesterday from the Kaiser experience that what it takes to get on the agenda. At our place, we're one of the CTSA sites, and I thought we actually made great progress in many dimensions relatively quickly. But what was our single biggest challenge, which I think we've overcome, was to get on that list from our hospital CEO and the practice plan, because they had operational priorities. I understand that, and research was not necessarily at the top of their list. And so it took us a long time, and as he implied, to get into that list. And that's something that we probably need to change, at least in our academic research centers, to get a cultural change of research, so it's a priority. And one argument we made was that the same kind of data you need to do research on your business model is the same kind of data we can use to do other kind of research. It's not as though it's two different worlds. So that sort of helped us make some progress. Clearly, I've been impressed with the need to engage more stakeholders, the payers, which I think, I'm not sure what the right year is, but certainly you are new on this discussion, and patients. I think I shared yesterday what impact the HIV patients played in the success of that network. It was incredibly important. We would never have succeeded without their investment and interest. So we got to get all the stakeholders talking to each other, and being from Wisconsin, we have a lot of silos in our state. I think we've had a lot of silos in the clinical research business, and we have to find ways to interconnect those. The issue which I'm still challenged with is how to deal with this on a global scene, because as someone alluded to recently, we have different regulations in different countries, different cultures, different ethical standards, and so how to harmonize those and move ahead with large, simple trials using electronic health records is something I have yet to get my head around. However, I must say that some countries are far ahead of us in the electronic medical record era, and so we may be able to learn from them as well as them learning from us. So I think those are some thoughts that I had written down that were stuck in my mind from today's discussion. And I don't know, Rick, I guess we should adjourn for the last session. I'm not sure what the last session is, but before we do that, I want to ask my colleagues if there's any additional comments they would like to make. We've said everything we have to say. All right. Well, I think that I will adjourn this session, and Rick, we can talk about take a 5-minute break and regroup. Thank you so much.
Thank you.